Today, I am joined by John Canion. He's a nurse practitioner who is seriously concerned about the state of his profession. He recently penned the 2023 report on nurse practitioner education and the need for change. John, welcome to the show.
Hello. Thank you for having me.
Tell our audience a little bit about yourself.
Started practicing as a nurse in 99 and started as an NP in 2005. I initially board certified in family practice, and I did the grandfather route to get my emergency nurse practitioner because I primarily work in the emergency department, but I've worked in different areas: urgent care, family practice, critical access, that kind of stuff.
What area of nursing were you working in?
I did a little bit of everything. The only things I did not do was labor and delivery and OB.
What was it that motivated you to become a nurse practitioner?
Okay, that's an interesting question. I was actually working as a nurse in an ER, and they had PA students coming through the ER at the time, and the doc was asking them questions, and I thought, well, I know everything. I know the answer to all those questions. And I was like, why didn't you go to PA school? And so I started applying to go to PA school because I was working as essentially a locums nurse at that time, or an agency nurse, making probably the top 5% I'd ever make in my career. And I was 24, 25 at the time, something like that. I was pretty young. And I said, well, I'll never have upward mobility outside of becoming an administrator or a chief nursing officer of a large place, which I don't want to do. So I started looking at going to PA school, and one of my colleagues said, well, why don't you become a nurse practitioner? I said, I don't, what is that? And so I started looking into it and thought, well, it's kind of like a PA, kind of does the same thing. Okay, well, I can do that. And I'll apply to both, and whichever one I get into first wins. I had a wife and small kids, so I couldn't afford to take a break and go back to school full time. So there was one program in the state of Texas that allowed you to work full time and still go to school. And this place, instead of going to school 5 days a week, you went to school 1 day a week and then did all your clinicals on your other days during the week. I did that for about 2 years. No, it was pretty rough, but doable.
Now, when you were going through, this is really before the big change in education. So it sounds like you were when you were attending your classes, even though it was a little bit more flexible, were you in
In
actually in
person, yes.
classroom
Yeah.
settings,
Everything was in
learning
lecture. Yeah.
the didactics? And then you
We,
were going to, of course, the bedside for your clinical rotations.
yes, yes. And where ours was at the time, the focus was to try and put us out in a critical access or a rural setting to get to understand how that worked. And I mean, it was invaluable part of my education was learning to go out there. When I went out and did my clinicals, I was on call for the whole time we were there. So, and then when the doc got called in, he picked up the phone and called me and said, let's go. Okay. So, you got to learn how to do that and how to deal with it, how to work tired.
And that was really the way that training traditionally always was. And then things started to change. And so in your paper, in your report that you wrote, I really liked how you started it out by summarizing the 2010 Institute of Medicine Future of Nursing report, which was really a landmark report that argued that nurses should practice to the full extent of their education and training. They should be involved in higher education. There was a big push for a doctorate degree, and ultimately a call for nurses to be full partners with physicians and other healthcare professionals in redesigning healthcare. So it was very aspirational. However, you point out that that was in 2010, and here we are in 2024, and there really has been very little leadership or direction from nurse practitioner advocates.
There hasn't been a direction on how we're to accomplish any of the goals that they put forth. The one thing that they took out of that, it seems like to me, was that we needed more. We needed more NPs. We needed more. And so the goal was, it seems like, to produce as many as possible, because the numbers have just absolutely exploded over the last decade and a half. The number of schools have exploded. The number of students have exploded. It's inundated and saturated, and there's no jobs, which tells me that we're overproducing. 100% way overproducing.
So you're saying to me that your understanding is that there are not enough jobs for nurse practitioner graduates today?
Bureau of Labor statistics put out a report. Their estimation based off that report was that every field in every market in every state would be saturated and that NP jobs would not be available.
And yet the numbers have skyrocketed. You alluded to the
Mm-hmm.
numbers, but I'll just say them out for our audience. In 2010, which was when the Institute of Medicine report came out, there were 91,000 nurse practitioners. And then in 2019, just 9 years later, that number went from 91,000 to 270,000. And then fast forward, the latest numbers from the AANP from last year are 385,000 nurse practitioners. That is astronomical growth in a short period of time.
The whole idea between the NP from the very beginning was you got a nurse who'd been a pediatric nurse for years and years and was exceptionally good. And then you just added a little bit of education on top of that to make them move them to the nurse practitioner level. And that makes sense to me. But then you get to where we are now, where we have all of these straight through programs where you don't even have to be a nurse. You just come in with a bachelor's degree and we'll make you an NP in 18 to 26 months or however long that program is. So they take you from being uh, an accountant to a nurse practitioner next number of years. And then we've always talked about the number of hours required for training for nurse practitioners is 500 is the minimum, right? Most programs do more than that. I think the average is like 650. But the reason is because you had a nurse who'd been a nurse for a long time and they've been experienced dealing with patients and they knew were supposedly be able to tell difference between sick and not sick and could tell when it was something they needed to punt and move down the road to somebody else who needed to look at something. And now you're taking people who have had no medical training at all. I don't know how you can say that that's the same.
The most recent study I saw of family nurse practitioners estimated that 22% of students are becoming nurse practitioners through these direct entry programs, which means they've never worked as a nurse even one day when they get their nurse practitioner degree.
The number of hours of training is a problem for me when you look at direct entry for sure. It doesn't make any sense to me how the two are the same, especially when you went from saying that you needed an experienced nurse, then you can add this much to get to the end point. And now you're saying, well, now we're just going to change X, like X plus 500 equals NP. And now you're saying, well, no, we don't need X. It could be A or Z or any integer you want. And then just add 500 equals NP. Doesn't make sense to me. And I've already got problems with the number of hours anyways. It's just, I just don't think it's enough. And when I graduated, my program director came up to me and she said, well, John, what did you think about the program? And I just said, I wish I would have learned more. I wish I would have learned more. There's so much I don't know that I need to know.
And this was before the education kind of transformed. This is you doing a brick and mortar with real, it sounds like
In
excellent
class, yeah.
clinical experience.
We've got reports of people going and paying for hours and not ever showing up, or paying and going and working as a nurse in an office instead of actually being trained and then getting their hours signed off at the end. Got all kinds of things. Used to, your clinical instructor would show up at all of your clinical sites. Makes sense, right? If I have somebody that I'm training and teaching, I want to make sure that the person who's teaching them is doing a good job, especially when I'm not setting up the rotations, which is an antiquated system. I may not know. And then I go and I'm getting bad information. I'm not getting up to date standards or whatever. Or, I go in and we just shoot the ham the whole time. And part of the problems become the students that I get. I would get students and they just didn't know. And I would take them and I said, this one example, I had a student who came to me who was fixing to graduate, came in with a patient. Oh, this patient comes in with chest pain and it's kind of a burning sensation across their chest. And I go in and see the patient and I lift the shirt up and she's got shingles. And you go back in the room and I'm like, well, did you examine the patient? Oh, yeah. I'm like, well, let's go back and examine the patient together. And then I didn't lift up the shirt. I'm like, well, you didn't examine the patient. After that, I started taking all of my students and making them do a physical exam for me when they came in. And most of them could not complete a physical exam because they didn't know. They didn't know how to examine a knee. They didn't know how to examine a shoulder, right?
And for anybody that's listening that thinks like, oh, this is just one person's experience, there's a very nice study of family nurse practitioner students that showed exactly what you're describing, which was that a significant percentage of students had serious deficits in knowing how to do really basic things like take a history, perform a physical exam, and then certainly differential diagnosis. There were students who had never once prescribed a medication during their training, and yet some of them will graduate and be practicing independently. What was it that got you motivated to start speaking out about this topic?
Well, I didn't realize how bad the issue was, right? I didn't know. I didn't know what I didn't know. So I was seeing these students. I went to the school and I'm like, hey, we need to work on this. So then I worked as a professor at the school. And I realized that that wasn't going to solve anything doing that. Somehow out of the blue, I got into a Facebook group of nurse practitioners. And we sat down and started talking with some people. And we started realizing in these groups how basic some of the questions were that were coming out. How I just flabbergasted and go, how do you not know the answer to this already? Was this not? And I assumed wrongly that everybody got the same standardization in their education. And my assumption was everybody got similar, maybe not the same because we had to find our own, but at least similar clinical training, or at least similar didactic training. And then when I started actually quizzing my students and they didn't understand, I'm like, didn't you take a pharmacology class? Oh, yeah. I wrote 6 papers and we did discussion board questions. Well, did you take any tests? No. Like, how is that? How are they testing your knowledge? I don't understand. And then I do the same for a physical exam course, do the same for their pathophysiology. And I just get to where I just am absolutely floored. I'm like, you got to know this stuff. CCNE, which is one of the credentialing bodies that credentials the majority of NP schools, not all of them, but there's 2, but this one credentials more. And they changed their rules because of our campaign to where the school was now responsible for placing students. And this was just pre-COVID. And then we were giving them some time, and then we were going to test to see if this was actually working. And during that time, I think there's quite a few students had started to complain. Some of them got run out of their programs because of the complaining. And the CCNE, unfortunately, requires the complainant to be at the university and requires them to provide their name. So they have to put their name on the report. They can't do it anonymously, which means, of course, there's going to be retribution against that person. That's why when we have corporate compliances, everything can be anonymous, right? The reason for that is so you don't have retribution. It's a similar concept, but you can't, because if you say anything, then they're going to come after you, and then you're out of luck. Since that came out, I'm only aware of one school that the CCNE took action against. And the rest of the reports that I've been told of have had no action taken. And then, of course, we were waiting, and then COVID hit. So, but now we're post-COVID essentially, and there's no change. They're not doing it. And the problem is the people who run the CCNE are the people who run the schools. So if you have the foxes guard the hen house, it makes it very, very difficult to change, even if the rule's in place. Unlike our PA counterparts who have to have the clinical sites in place prior to students enrolling. We didn't get that change made. That would be ideal, because then all these fly-by-night schools and all these schools that are pumping out 300-400 NPs a semester wouldn't be able to do so, because they'd have to take care of the clinical placement. And when you take care of the clinical placement, now you are saying, I'm responsible for training this person, versus, oh, well, we just did the academic education. The clinical education was by Dr. Smith. I can't believe that he wouldn't teach her that.
Your goal is to try to hold these schools accountable and responsible to ensure that their graduates are actually prepared to take care of patients.
Yeah, and not even just that initially, but now I want them to be better. I want them to be better than me. Each generation needs to be better than the last. Nobody's actually critically looked at NP education. I mean, by the standards by which we're measuring, then yeah, if people are passing boards at a high rate, that means you're doing a good job. Well, is that the appropriate measure of success? I don't know. I mean, our number of lawsuits are going up. Is that because we're not training enough? Is it because there's more NPs? I don't know. I don't know the answer to that. But what I can tell you is the people who are coming out are not getting hired. Companies and employers are preferentially looking for experienced nurse practitioners over new grads. They don't want to hire new grads because they know they'll have to train them. Here's my question. and this is my question anytime I talk to one of my academic friends. When you go and you see a nurse practitioner, would you be comfortable with them being from any program in the country, not knowing their background at all? That's my question. Because if the answer is no, then that means we're not doing what we need to be doing. And my answer right now is no. I'm not comfortable with that. There's some that I'm comfortable seeing, yeah, some that I know that are pretty good. But the question is, are they succeeding because of their training or in spite of their training? It's a concern, man. I mean, because I'm
Yeah.
getting old. I see the mistakes coming into the ER all the time. I actually sat on the American Association of Nurse Practitioners Education Enhancement and Sustainment Committee. They called me and asked me to sit on the committee, so I did. Part of that was signing a non-disclosure agreement, so I can't speak of anything that occurred, and that also kept me out of this space for a little while. But I wanted to try to fix our problem from the inside. One of the problems is they say there's when I talk to my academic friends is there's no literature that says there's any problems, even though the nurse practitioner journals state that they won't publish anything that's anti-FPA or puts us in a bad light, right? So when I write something like this, which by God, it's not a great paper. I get that. I haven't written anything academic in 25 years, right? So I get that. The point of the paper, the gist is the issue, right? Is somebody we need to look at our education and say, we have holes, we have problems, we need to fix the problems. And if you go to publish something like that, and the journal's like, well, we're not interested because you said that you don't think we need independent practice.
So there's no literature, but on the other hand, if there were literature, it wouldn't necessarily get published. And
Right.
further, we have had independent practice out west for what, 20, maybe 30
Long time.
years?
Yeah.
So how come there are no randomized controlled trials evaluating care provided by
It would
unsupervised
make sense.
non-physicians?
It would make
There should
sense.
be something at this point if anyone were interested in looking at that data.
That would make sense. There's states where you can practice. Arizona's independent practice. You can do that study. You could do that study, and you could argue to a IRB that it's valid based on the state laws, right?
Yeah.
You can make that argument and do the study, but they're not done. And I don't know why the answer to that is. I don't know if there's a fear. Most of the studies are highly that I've seen are flawed and just have all kinds of problems. There was one that came out, I guess 2 or 3 years ago, that was out of emergency medicine, which showed similar outcomes between ER docs and NPs and PAs. But the problem is, what kind of supervision do they have? I've worked in probably 40 plus ERs in my career. I do a lot of locums. So every place I go is different. Every amount of supervision at every place I go is different, even within the same state borders. So Texas is a supervised state, so we have to have a supervising physician on all of our cases. And in some cases in Texas, I work very independently and only talk to the doc when I need to, or when I need them to review a case. And then they have to review X number percentage of your charts, right? In some cases, in some ERs I work at, I bring every single patient to them like I'm a resident. So when you look at this study that was done a couple of years ago, there was no description of what the independence of the practice was. How independent? How often were you talking to the doc? Was I sitting next to you and going, "Hey, would you look at this toe, man? I'm just not sure what's going on." And then I finish the chart, have a great outcome, but I've already consulted you. So does that count as independent? Not really. How much of the supervision was there? How much of time did I actually spend? I don't know. And I looked at that and there was no description of it. So I can't really look at that, even though they say there's similar outcomes in their conclusion. I don't know how they got there. So you can't really draw that as an example. And it's actually one of the ones I wanted to use in my paper until I started looking at it. And I'm like, this doesn't make any sense. So our literature is kind of not great either way. And it's just, I mean, there's not been, like you said, a true randomized controlled study to actually look at this, and we could do it. I really think our education as a whole just needs to be complete revamp. I don't think it's good enough.
So the 2019 closing ceremony of the AANP conference had a lecture by Margaret Fitzgerald, who I guess sells some of the testing courses and things like that. And in her closing comments, she put up a photo of a smiley face with a zipper for the mouth, and it said, "Sometimes the strongest voice is silent." And she was telling the attendees, that if you're opposed to full practice authority, you need to stay quiet. So I'm assuming that means that you are not super popular among the establishment, or even I wonder how your colleagues are approaching you with the way that you're speaking about your concerns.
A lot of nurse practitioners really do see the problems and are speaking out now and starting to become more vocal about the problem. But we can't get published on it. You can't publish the data, so it's not going to ever make it in the academic mainstream. Like, I mean, I did this paper and 1,000 people have seen it, maybe 6,000, 7,000. There's 400,000 nurse practitioners. You know, I mean, you can't really sway minds if you can't get people to look at the issue. And one person just put, "That's too long. I didn't read it." I mean, it's too long. Not going to read it, which is fine. I get it. People are busy. But when you're looking at a problem and you say, yeah, there's a problem. Well, we've got to have a solution. You've got to have direction. First, you have to recognize that there's a problem. My solution may not work. It may not be the right way to go. It may not be. I don't know. But until it gets tested, there's no way to know. My solution, 6,000 hours, significantly more than the minimum of 500, right? And we actually fought to get the minimum number of hours increased to 2,000. And there was rumor that they were willing to do that. And when it came to brass tacks, they're not going
Didn't
to happen.
happen.
No, they're trying. They're going to go up to 750, which is better than 500. But I think you have to have additional training in a specific area, so I can come out. And I don't even think, be honest, I don't even think that 2,000 as a generalist base is enough to go into one area and be a specialist there, even in family medicine, because as well as I do, family medicine is its own specialty. You
Right.
have to know it. If you don't, like, I couldn't go out and do family practice now. I talked about in my paper, there was nurse practitioners who got done with NP school, started practicing, and just go home crying every night. Crying every night because they don't feel prepared. I
Right.
I I have one text me the other day that I just don't feel prepared. I don't feel like I can do this. I don't know what happened. That I think having this additional training and having the specialization and doing that is the right thing to do. And I think it would put us in a better position moving forward. And it'd make us better at taking care of patients. You have nurse practitioners who say, "Well, we passed the same test. It was the easiest test I ever took." And the family nurse practitioners get mad at me for that. The emergency nurse practitioners get really mad at me when I tell them it was the easiest test I ever took. All right, it was easy. It was too easy. And like, well, instead of saying, well, get mad at me for saying that, why don't you ask me why I think it's the easiest test I ever took? What do you think should change in order to make it the appropriate level, to make it an entry level? And this is another thing most people don't know. Our test is not a mastery test. And so it's not a test of mastery of skills. It's an entry level to practice exam. So the test is supposed to be testing your knowledge so you won't kill people, essentially.
Hmm.
It's not a mastery subject. Like when you take your boards, yours is a mastery level test. Ours is not. Ours is an entry to practice exam. And then they tried to solve it with the DNP, which initially was supposed to be a clinical doctorate, as you're aware. And it actually erased a whole bunch of the other doctoral nursing pathways in order to coalesce them into this thing. But the problem is, NPs looked at it and go, "Oh, they don't want to do that. There's no clinical. Why am I doing this? This doesn't make sense. What extra benefit is this going to get me?" We all talked about it when the DNP came out. That doesn't make any sense. Well, then they're like, "Oh, well, by 2012, everybody's going to have one. Oh, by 2018, everybody's going to have one. Oh, by 2020, everybody's going to have one." And so all these schools are popping up. And then online, I don't know if you've looked at any of these online, but I have, because I've considered going back and being an academic full time. But every time I look at these programs, I just go, this is not going to benefit me at all. There's no benefit. But also when I look at the programs, they say it's your clinical DNP, your clinical doctorate. Well, not really. You're not teaching anything clinical in the doctoral portion of this. So even somebody who gets their nurse practitioner DNP at the same time, it's not a clinical doctorate, but many call it a clinical doctorate, or they like to use the title doctor in a clinical setting once they get it, which drives me up the wall, because they say, well, the DNP is equal to like a doctor of physical therapy or a PharmD. Well, I mean, you can call it that. That's fine, but it's not clinical in nature. Every single PharmD is a pharmacist. Every single physical therapist that's a doctor of physical therapy is a physical therapist. Every DNP is a nurse, not a nurse practitioner, not a CRNA, not a midwife or whatever else. They're a nurse. So that doesn't impart any advanced clinical knowledge to assume that you can use that title. And
Right.
it's the same thing for me as a nurse. If I had my DNP to walk in the room and say, hey, I'm Dr. Canion. No, I'm not. In that role, I'm nurse practitioner. And I always introduce myself, hey, John Canion, I'm your nurse practitioner. Very nice to meet you. What can I do for you today? As opposed to, hey, I'm Dr. Canion, your nurse practitioner. Well, that's confusing.
It is.
That doesn't make any sense to me. So I'm assuming you're a doctor. When you introduce in the United States, if you walk in the room and introduce yourself in a medical setting and introduce yourself as doctor, they're going to assume you're a physician. That's the assumption, and it's a pretty good assumption based off of history. And that's why we don't use that title in that setting. It's not appropriate. In any every other setting, fine. That's fine. If you're in academic setting or any setting that's non-clinical, happy to use the title. That's appropriate. But in the clinical setting, it's just not appropriate because it's not a clinical doctorate. It doesn't teach you anything clinical.
I like the ideas that you lay out in your proposed solutions. First of all, you say that we need to improve our admission requirements because we know that there are a lot of NP programs that have 100% acceptance rate. So anybody that applies is getting in. So standards can be really quite lax. So you would suggest that number one, they need to have really be screening candidates. They need to make sure that they're actually interviewing people, making sure that they're committed to the profession. You would want them to have had at least 2 years of nursing experience as well, just even before they started
Minimum.
NP school.
One of my core tenets is making sure you're a nurse practitioner. You're a nurse first. You should have been a nurse. You should have spent time at the bedside. You got to learn how to be a nurse before you can learn how to be a nurse practitioner and in a critical care area because
Right. So they
it
need to
just,
know what sick looks like.
yes, that's one of the most, I mean, when I came out of school, one of the reasons that NPs were at the time, we were coveted above our PA counterparts because of our ability when we came out to recognize sick and not sick, because we could see, I could walk in the room and go, oh shit, something's wrong.
You're speaking out and trying to put some pressure on leadership to really, get back to what made nurse practitioner profession really great, which was, having worked as a nurse and bringing that nursing approach and then really understanding and studying and getting a solid foundation. And then to me, working really closely with physicians, which you've done for so many years, and then still having access to a physician in the event that there's something that's not following the way that you would expect it to. And I think that more voices like you have to speak out and put pressure on your leadership because I don't really see any motivation for them to change.
There's not. I mean, I've had people call me and scream at me and be very upset with me when I put this paper out. And it's published on Substack and it immediately got a whole bunch of reports for spam, which got it taken down, which is back up now. But it's things like that. Well, we got to shut it down. Well, how about you critically look at it and say, hey, let's have a discussion.
I really want to applaud you and I want to thank you for speaking out. I know it's not easy to talk about this. It's an emotional topic. People get upset, but we also have to say what's right for our patients because
Yeah.
ultimately that's why we're all in
I'm
our
sure they're going to get
profession.
upset with me from coming on and talking to you too. But yeah, I really didn't want to say anything. I really didn't. I didn't want to. I wanted to take care of it from the inside because I thought we could switch it, but there's too many people too invested in full practice authority, which is one of the things they yell at me about. They're like, well, you're going to ruin the chance of getting full practice authority. And I said, well, maybe, but maybe if our training was good enough, I wouldn't be able to do that.